What's going on, everyone? Good morning. Just finished a workout here in our MoveWell private gym, which is in my garage. But anyway, just finished doing deadlifts and swings. It was a leg workout. Had some functional movement, reinforced patterns at the end. Don't have a bunch of machines here. I have kettlebells and free weights. And anyway, this is a thing that we actually teach patients to strive to actually fix them through exercise. Novel concept, right? So anyway, if you haven't already, grab a copy of our book. We send it out for free. Well, you just cover shipping, okay? You get the book for free. It's an 18 chapter quick read. We talk about a lot of the concepts that we do these Facebook Lives on, we do podcasts on. Check out our podcast if you haven't already. Have close to 100 episodes in there. What I want to talk about this morning briefly, and I'll flip this around in a little bit so this isn't flip-flopped, but it says Chiropractic FM with MoveWell U. Do I really need to know this stuff? And I'm talking about shoulder dysfunction. How do you look at it? Chiropractically, posturally, and functional anatomically. Okay, so I'm gonna flip this around. You're gonna get a tour of the home gym. Flip. All right. Let's see, that should work. Let me get a little closer too. Boom. All right, cool. So here's what we're covering. We're covering shoulder issues and just how to think of these. And I want to talk about a couple of little tips or rules that when I learned this and I started explaining this to patients and started looking at this differently in practice several years ago, it made a big difference for my outcomes. Because the way I was trained initially with shoulders, we weren't doing exercise prescription, we weren't doing any kind of rehab, it was just all straight adjusting. And so someone's got a shoulder problem, what do? You said an anterior inferior humerus 90% of the time, right? There's some other things you can do with shoulder adjusting. Not that that isn't extremely helpful and warranted in a lot of cases, but that's a piece of the story. That's a segmental or a joint component. And there's other components involved here. So let's just cover this real quick. Shoulder, okay? Now, I'll have to follow my title here where I talk about chiropractic-ally. How do we look at this? Chiropractic. What are we really taking care of? Nerves. We're trying to affect nerves. We're affecting joint. We're ultimately affecting spinal cord tension on the spinal nerve root. All the fancy new chiropractic neurology stuff that explains how different reflexes and whatnot are affected by joint proprioception and all that fun stuff. So there's lots of studies out there talking about how chiropractic is really beneficial for nerves. So let's just talk about a shoulder issue. There's a muscular component that's controlled by nerves. The nerves need to be controlling the muscles properly. The rotator cuff does what? It sucks the head of the humerus into the glenoid fossa. And that's the main job, is to hold that thing stable so that you have all this range of motion and the shoulder doesn't clunk around or dislocate or do all kinds of funky stuff. So the nerves going to the rotator cuff need to be working properly. There's other issues that get into the next component. And it crosses over here because as chiropractors, we are affecting posture indirectly, even if we're not doing it directly, even if we're not doing like postural corrective exercise and traction and stuff like that, we are affecting the posture indirectly in the sense that someone's posture can be compensated into a thoracic hyperkyphosis or a forward head translation because initially that was an antalgic posture. They were in that position to try to avoid pain, and in that position, it makes things very dysfunctional for nerves and just structural functionality of the scapula. Thoracic hyperkyphosis, the scapula now fits on that increased convex surface, okay? I should say the convex surface of the scapula, the concave, convex, sorry, I'm thinking about this in my head. It's not like this, scapula's like this, okay? And essentially if there's too much curve, the scapula doesn't fit properly, or the scapula dumps forward. And we know that as the scapula dumps forward and you try to raise your arm up, now that subacromial space gets impinged, shoulder problems, supraspinatus pain, bursitis, issues because of structural postural issues. Posture is a big one in this. And a little functional movement tip, and then I'll cover one more component that I think is super important. I'm talking about this bird's eye view first. Functional movement wise, there's a rule that before you try to improve shoulder mobility, you have to improve what? This is a quiz question. So there's a rule that says thoracic mobility before shoulder. So what's that mean? That means if someone's got a shoulder issue and they have a decreased thoracic mobility, so they're lacking thoracic rotation or extension, which you're gonna see in a lot of the thoracic hyperkyphosis patients, upper crossed syndrome types of patients, you really don't have any business trying to correct the shoulder until you fix the thoracic spine, until you start to address thoracic mobility. So in the sequence of programming and correction, you wanna be doing thoracic mobility protocols before shoulder mobility. What's thoracic mobility stuff that we do as chiropractors? We adjust joints. That helps take fixated segments within a whole curve, like a thoracic curve, and get those segmental joints moving so that the entire curve even has a chance of changing its shape because it's not being impeded by the segmental issues, right? So that's our segmental adjusting approach. Postural approach for thoracic mobility. A lot of thoracic mobility people have a thoracic hyperkyphosis. It's not always. You can have a super flexible female that's 15 years old that just has bad posture that hangs on her joints. Doesn't mean she necessarily has a thoracic immobility issue. Could just be motor control, bad posture, weakness of the posterior chain. You might not have to do anything to actually increase mobility in the thoracic spine. That's why we're checking functional movement. We're looking at, does this person have proper thoracic movement? Because we don't want to be wasting our time with a bunch of protocols that really aren't warranted for the patient, okay? So back to the functional movement thing, and I'm gonna elaborate, I'm gonna close on that. And just real quick, if you're just tuning in, if you haven't already, grab our book. It's 18 chapters, it's a quick read. This will set you on the path to really understanding how we look at this stuff from a segment, posture, movement standpoint. Very complete way of looking at this in chiropractic practice. Patients love it. It gets great results, and it's just a much more enjoyable way to practice, in my opinion, the world according to me. So, Movable Secrets, you can grab the book for free. You just go to moveableuniversity.com/book, and you cover shipping. We'll send this out to you. We have a limited number of these. We had a big box we ordered, and I've been pushing this because I want to send all of these out to chiropractors that have been following our stuff that are interested in learning more about this. So we're sending these out for free, so grab one. moveableuniversity.com/book. The link is in the topic of this post. So last thing here, we're gonna talk about, I'm gonna erase this, okay? So now we're gonna talk about one more thing that I think is really a cool eye-opening way of thinking about things. I did a video about this the other day on pelvis, hip stuff, and these patterns exist all throughout the body. There's not an unlimited number of patterns, there's a handful, but this is a very important one. So from a functional movement standpoint, let's just talk about someone that's got shoulder dysfunction, and maybe they have just the classic, rounded forward shoulder, they have impingement when they bring their arm overhead. How do you start to figure out, after you get them out of pain, after you do whatever thing you do to get them out of pain, which might take a couple of visits, you're not fixing them when you get them out of pain, you're just getting their attention, you're getting them far enough along so then you can actually correct them, okay? There was a Facebook post yesterday where a guy was talking about his PVA is 6 visits, and people were like commenting, hey, how come your PVA is so low? And other people were like, well, your PVA doesn't have to be higher, that just means you fix people quicker. And I jumped on there and I said, look, let's just be honest, it really depends on what you're trying to accomplish as a practitioner. No one's fixing anything in 6 visits unless you're looking at like a 3-year-old. Okay, it takes more than 6 visits to get someone out of pain, if that's, most of the time that's why people come see you, to then do proper assessment when they're out of pain to see where they're at from a functional standpoint. If you're looking at fixing joint issues long term, if you're looking at preventing a disc from degenerating and going down that path, educating the patient, proper activities of daily living, things they should do, shouldn't do, sleeping position, standing position, teaching them how to do proper movements like breathing, hip hinge, core engagement, and then doing something to actually help improve their posture, and then give them some home care to do. If you can do that in 6 visits, you are like a super ninja and you're spending probably 12 hours with a patient each visit, more power to you. From what I found, most patients don't want to spend 12 hours per visit. But anyway, I'm being a little sarcastic. But anyway, back to this functional movement wise, if you have a shoulder issue, we're gonna look at a bunch of different things. First off, is there a thoracic mobility issue? That's like the first thought process. If there is, address that, okay? Second, is there an upper crossed syndrome type of position. Forward head, doesn't even have to have a forward head, just gonna have rounded shoulders, thoracic hyperkyphosis. If you go in and just palpate the musculature, is the pec really, really, tight and overactive? And are the upper traps tight and overactive, levator scapula? Is the deep neck flexors weak? You can put the person face up, chin tuck, pull their head up. Are they shaking? Are there rhomboids, lower scapular stabilizers? Are all of those muscles weak and inhibited? If so, you have an upper cross syndrome. Now, another thing, you check range of motion, okay? You should have internal rotation, you should have 60 degrees of internal rotation, 90 degrees of external rotation, 150-degree arc of motion. That arc can be clocked forward or back, especially in baseball players, it's oftentimes clocked back. You're not gonna try to change that and increase it past the 150-degree arc. So, for example, if they're 40 degrees internal, okay, now I have to do some math, but 110 degrees external, it's still 40 plus 110 is 150. They still have the arc. You're not going to want to mess with that because that person has developed that through doing things like baseball, especially if they played since a young age. You don't really want to mess with that. But people should have a 150-degree arc, or at least pretty darn close to that. So you're going to want to measure range of motion, all right? Do that in a good, reliable way. So then, once you measure range of motion and you're palpating around, you're figuring out what's going on with them, oftentimes what happens, very common thing, is people will have posterior delt hypertonicity, okay? It's turned on, it's very, very tight, and it bothers them. And then they have weakness of the external rotators of the shoulder, okay? Which is infraspinatus, teres minor. Infraspinatus, teres minor, okay? They have an overactivity of the pec. They have weakness in the deep neck flexors. So like, what's the whole pattern and the thought process of this now? And this is the same thing we covered last time in the hip, is that the whole order of attack that you have to do with this sort of dysfunctional pattern is you can't just get in there and start strengthening the weak external rotators. And if you try to do that, you're not going to get very far with the person. And when you do strengthen the external rotators, the weak ones, you have to do so in a way that you inhibit the overactive synergists, which means the other muscles that are trying to create some level of external rotation, you have to put your arm in a position when you do this activation or strengthening exercise, and you have to do it in such a way that you're not just exercising the muscle that's already overactive, accomplishing the external rotation. So you need to do things like bring the arm into slight flexion. Why do you do that? Because it makes it harder to fire the rear delt. You want to adduct the arm, pull it in towards your rib cage when you're externally rotating. Why do you want to do that? You want to reciprocally inhibit or shut off the deltoid from helping, because the deltoid's going to help a little bit with external rotation, that lateral delt. And those are just some of the tricks and the things that have to be done to really do this stuff properly. It's not good enough to just be like, grab a band and do this. You have to be very specific if you want to get better outcomes. But then, backing up a little bit, you have to say, what opposing joint action muscle, okay, could be overactive and tight that needs to be toned down first? And when we look at this, external rotators, internal rotators. So what are some of the internal rotators? Depends if the arm is overhead or down, but lat, pec, okay, so those are internal rotators. If those are really tight, also teres major, if those are very tight, then those will actually reciprocally inhibit. They'll shut off the opposing muscles that you're trying to activate. So you're not going to get very far with getting the rotator cuff, the infraspinatus and the teres minor, to activate and turn on until you tone down the opposing joint action muscles. So there's an order to this. So you start with toning this stuff down first. You got protocols that you teach the patient to do. Then you tone down the overactive synergist, the rear delt that's really tight and bothersome, okay? Then you go in and activate the infraspinatus and the teres minor. You don't stop there. Then you want to progress this, okay? So you've restored some range of motion, you've got things active. Now you want to progress this to a loading movement, a functional movement pattern. The best tool of choice when a patient's ready for it is a kettlebell, even if it's really light. You do shoulder packing exercises. If they can do this, you do an overhead press exercise. Okay, very, very important that you have to end with loading, or you just kind of to an extent wasted the time of the patient and yours. You're not going to have any long-term stay put value until you load the movement. That's what ingrains this neurologically into someone's brain and their body. Then they have to have a process where they're practicing this stuff. And if you don't use it, you lose it, especially if you just spend all this time, like let's say your staff is trained in our systems inside of our program, inside Movable University. They're doing this. You're in your room adjusting, you're overseeing them. They're taking patients through these awesome systems. You're prescribing what to do. Everyone's happy. The patient needs a at-home resource to be able to follow this along. So conveniently enough, we built this thing called the 12-week transformation, which is pretty cool. We actually talk about it here in the book, right here, 12-week transformation. That's in chapter 4. Okay. So the 12-week transformation is a membership site that we built. All of our Movable doctors get a clone of this, and it has an exercise library inside of it. So you map out what's going on in a journal with your patient. They can go home and click on various exercises, videos pop up. We filmed hundreds of videos to do this. So anyway, the moral of the story is this is how you need to be looking at a shoulder. If you really want your patient to get better with this, and you don't want to have to be limited to only being able to help a handful of patients per day, but you want to be able to take this amazing level of clinical care and help the masses, you have to have automated systems to leverage your time, your staff's time, and keep the patient engaged and give them resources to do out of the office. So if you haven't already, grab the book, movableuniversity.com/book. We'll send it out to you. If you have been following our stuff and you want to find out a little bit more, like if this is right for your practice, schedule a demo with Vlad. So you can just go on our website, movableuniversity.com. There's a button there at the bottom. It says schedule a demo. You get on his calendar. It takes about 20 minutes. And he can go through and ask you some questions and find out pretty quickly if this is something that looks like it would work for your office. This is not for everyone, I'm telling you. This is not for every chiropractor out there. It works for most, but not for everyone. And you can talk to Vlad, he can tell you a little more information. If you have any questions, you can comment. You can always reach out, message me on Facebook as well. And my name is Dr. Todd Pickman, and in case that's not showing up here. And with that said, have a great day, everyone. I gotta get ready and go see patients.